NSAIDs are in like the top 5 drugs for which people get admitted to the hospital, the others being like anticoagulants. We see all of those mistakes. Diuretics, your potassium's 3.2, okay, fine. Antibiotics and hypoglycemics, that's the kind of the list. You know, there is this kind of belief that we got to be a lot more careful with our use of drugs, and that a lot of people are getting hurt by them because of their indiscriminate use. And so this paper number 1 basically says, well, here's a study, 18,000 people got admitted to the hospital. How many of them got admitted to the hospital because of drugs? And they said, in this study, 1 out of 16 people came in. 80% of those 1 out of 16 absolutely was related, and the other 20% we think is probably was related. So 1 out of 16, is that a lot? Well, and how serious was it, kind of thing. Paper number 2 says the range of this is between 3 and 23%. So this paper here, the first one, 6.5, tends to be on the low side. You know, these are generally older people, multiple comorbidities, taking multiple drugs. And I guess that's one of the reasons that people wanted us to do. In the States, we do this thing called medication reconciliation now. Those of you in Australia basically have been spared this, and Canadians have been spared this cross, which is largely the garbage in, garbage out phenomenon. They tell us the drugs we're on, and we put it down on a piece of paper and hand it back to them. Is there more to it than that? Do you sign on that piece of paper, yeah, this is okay, I've reviewed these drugs? No, we don't sign. We're not going to take any responsibility. We don't know the ophthalmology drugs. Yeah, and we happen to find that you're on 5 different NSAIDs. Well, we'll probably try to intervene there, but that's about it. And you know, they were mentioning earlier that it's really intended for the in-house people, but we are disproportionately burdened by this because we see 60, 70, 80, 90, 100 patients a day and have to do this for them. They don't admit 60, 70, 80, 90 patients a day, and it is much more garbage in, garbage out. I told you the study we just did, pharmacist reconciliation, ER physician, ER nurses reconciliation, both elderly groups were on 7 drugs, except the list of the 7 had 4 different drugs on each person's list, because the pharmacist got 4 different drugs out of that 7 that they thought the person was on, and we thought they were on 7 drugs, but it wasn't the same drugs that the pharmacist found. So there really is a credibility issue here associated with that, but the underlying theme is medications can be problems. This paper, one of these papers said 1.6 billion is GI bleeding related to NSAIDs, 1.6 billion. We could take over a small country for that probably, I think, you know, nothing big, but something small. And so it's considered big bucks. Number 2 is a McGill paper, and it asks ER physicians, can you go through these cases here and tell us how many of those related, the youth, in your opinion, were drug-related? And this is 283 people, McGill over the age of 65. Adverse drug events were recognized in 11% of emergency room patients by the ER docs. So it's 1 in 9 now in the elderly patients. The more drugs the people were taking, the more likely they were to have a problem, as you might anticipate. And the older the patients were, the more likely they were to have a problem. One of the things about these drugs is that they're all not equally bad for your stomach, kind of thing, in terms of causing a GI bleed. Some people kind of try to tease that out, and paper like number 3 is a typical paper, not the best, but it looked at 125,000 nursing home patients, looking at the use of NSAIDs and looking at their GI effects. Hospitalized GI events is what they were looking at, and basically found that like naproxen and Sulindac, 3.9 times the risk of if you weren't on it, 3.3 times for men. Ibuprofen was low, 1.3. The studies basically said that if you're going to pick, the safest drug is probably ibuprofen. Lasts in the bloodstream only 4 to 6 hours, kind of thing, so it's not hanging around all the time. And it does seem to be, relatively speaking, the safer. They talked about like indomethacin and peroxicam, which I think is Feldine. That was the risk of a GI-related admission 2.4 times greater. So it ranged from 4 to 1.3 in this study. So it suggests that not all the NSAIDs are equivalent. The better paper is the one number 4. This is admitted GI bleeds who are on NSAIDs. This, I think, is a British study. 1,500 admissions compared with 20,000 controls, and basically they concluded that the overall risk of a GI-related bleed in admission was 4.4 times greater if you were on NSAID than not. Although, again, we're talking about relative terms, the idea is to suck you in and say, oh, 4 times greater. 4 times what? What's the absolute numbers? And the absolute numbers may be more acceptable. The safest drug was ibuprofen, 2.1 times greater for the risk of a GI bleed. Peroxicam, which was Feldine on the other one, which is in the 3s and 4s. In this paper of looking at 1,500 admissions for GI-related bleeds, the risk was 9 times greater. And the worst was ketorolac, 25 times greater risk. The Black & Decker stomach wrecker, as they say in the trade. So that's why this drug is so unusual in terms of it's no stronger than any other of the NSAIDs. There's no list of, this is the strongest NSAID, this is the weakest NSAID. Some drugs, some NSAIDs may be more effective for this person than that person, so there's individual differences, but you'll never see in a book strongest, weakest. So there is no ranking order. Ibuprofen's just as good as the most expensive drug that you can find. Indomethacin used to be considered, oh my goodness, indomethacin, terrible drug in terms of side effects, and it was viewed as very effective kind of thing. It's no more better than any of these others. But there clearly is a side effect ranking order for GI side effects. So that here's a drug, like ketorolac, 30 milligrams you give by shot, 10 milligrams you give by pill. Whoever heard of a drug where the pill dose is a third of the shot dose? It's usually the other way around. So this reflects and plus you're only allowed to take it a couple of days kind of thing after you've been on it in a hospital setting. I have no idea why people are so enamored with ketorolac. It's the only drug available in the United States that's a parenteral NSAID. Indomethacin is available for doing patent ductus in little infants, but certainly not in the doses that would be given adults. Yet in Australia, you got some other NSAIDs in Australia? Rectal indomethacin. That's it? You have no IV aspirin, IV anaprox, any? That's it? This is a world conspiracy, because in the Scandinavian countries they get IV aspirin, 3 or 4 IV NSAIDs, which never were adopted in the United States. And now ketorolac is off patent, so it's not $6 or $7 a dose now. It's less than $1. But no better than any of the others, no better. You can't show me a paper that says it's better, but people give it out all the time in ERs, maybe because they want to fool the patients. Got to give them a shot, got to give them something, but waiting here 2 hours where I can't give you, here's 2 ibuprofen, get the heck out of here. We got to give you, grind this ibuprofen up and shoot it in their butt is really what you're doing. Back pain, headaches, you name it, people are giving it out for. You're either a believer in this drug or not. I'm personally not. It's great for, because it's this prostaglandin synthetase issue. Prostaglandin synthetase issue is about pain, inflammation, and blood flow. And so it's good for, and smooth muscle, so it's good for kidney stones and gallbladder things, that's good. But that's very specific, and you could, if you have a non-vomiting kidney stone patient, except for the fact that ketorolac works good IV fast. Actually, it's interesting. If you give IM ketorolac, no faster than oral ibuprofen, no faster. Study head-to-heads, no better. So if you're going to do that trick, you're basically trying to fool the patient, but in terms of therapeutic intensity, onset of action, no difference. The most important paper here is number 8. So we got an interview of some people here who've got arthritis of the knee. Well, now, arthritis of the knee generally is not itis. You got degenerative joint disease, your knee hurts, but it's not hot, it's not inflamed, that kind of thing. It's just that you have, your knee is just given out because you're living too long or something like that. So this is not really an itis. It's called degenerative joint disease, is more technical correct. But we call it arthritis. You get arthritis in the knee. So here's some people. 100 people were interviewed between the ages of 59 and 90. Who were they? As we talked about before, if you want to extrapolate this to your population, 92% were white, 79% female, 69% had some college. So, a third of them had, the thing I think, 95% were unaware of the potential for ulcers, GI bleeding, or renal toxicity. 95% of these patients were unaware of those things, according to the survey. Once they were informed of these risks, they said, well, you want to take this pill or you want to try something else? 2/3 preferred an alternative medication, even if it were more expensive, the onset of action was delayed 4 weeks, and 4 times a day dosing was required. So if you ask people, and study after study about people and their awareness of side effects, and are they willing to take a chance with them, all of the studies always say patients if they're adequately aware, they'll back off because they are disproportionately, apparently, afraid of the side effects and would rather take another alternative. Well, here's a fabulous paper that says ulcers, renal, blood pressure, heart attacks. I think I'd rather try that acetaminophen first kind of thing. 2/3 before an alternative. The only alternative we're talking about is non-NSAID, which is basically acetaminophen. I'm willing to take more expensive, delayed onset, and 4 times a day dosing. Because one of the things they say now is when you take naproxen, you only have to take it once a day. Well, that's cool, or some of these others. But these people were willing to give that up because they became aware of the side effects, and they said, I don't think so. So this would suggest that if this was extrapolated to the whole, that people who are on NSAIDs for a protracted period by their family doctor, if given the option, probably would prefer something safer first and say, let's try that. And if that don't work, well, then maybe I'll be willing to accept more risks down the road with this other drug. Especially when you're talking about a non-inflammatory process, like your knees acting up. Yeah, you can try acetaminophen. Don't work, okay, you can try something else, try some ibuprofen, that kind of thing. But that would be and the World Health Organization does have this analgesic ladder that they talk about, where you're starting out with acetaminophen. Acetaminophen doesn't work, then you try this, ibuprofen, then you try some combinations, et cetera, et cetera. Are the GI problems with the COX-2s less? Probably the biggest expose kind of thing was in number 9, the CLASS trial. CLASS trial was a study that looked at GI side effects of one of the COX-2s. I forget what it was. What is it? Was it Celebrex? And in paper number 9. Okay. And at the end of 6 months, they had less problems with GI side effects with Celebrex than not in the first 6 months. So they reported the first 6 months. Yeah, it was better. Less GI problems. But there was no difference at the end of the 12 to 15 months of the study. They only reported the first 6 months, but there was no difference at the end of 12 to 15 months. So the only way there could be no difference at the end of 12 to 15 months is that although the first 6 months there was less GI problems, in the last between 6 months and 15 months there were more GI problems, because that's the only way you could get at the end of the study. It was worse. So this was kind of viewed as this was a dirty trick kind of publication, because the study was published prematurely when they were planning to run it out for the whole time. They did run it out, but they only reported the first 6 months. In Canada, where they have a more controlled view of what's being given out because of their system, when the COX-2s became available to prescribe to the patients, there was a substantial increase in the prescription of NSAIDs, throwing in the COX-2s. And as the COX-2s were increased, there was no increase in the non-COX-2s. The COX-2s were added, and this paper says that the admissions for GI bleeding went up as soon as the COX-2s were added. What drugs can you use to protect against the stomach? Can you use cimetidine or Tagamet or any of its cousins? The answer to that, according to paper number 12, is a review of 112 trials. Now here's a good example. All of the money and time and grief and work went into 112 trials to ask what GI protective drugs are there. Do you think 1 or 2 or 3 decent studies would have answered that question? They put together 112 trials. Were they all great trials? This is like, can you make a 6th grader out of 3 second graders? Yeah, it just doesn't work that way. So The number needed to treat to prevent one symptomatic ulcer with H2 blockers and COX-2s was infinity. Infinity. So basically, these drugs don't protect you. So what the drugs that do protect you are the purple pills, the Nexiums of this world kind of thing, the proton pump inhibitors. So the number needed to people to treat to prevent one GI or a symptomatic ulcer with a COX-2 is 14, and 17 with a COX-2 selective NSAIDs, because some of those not all of them are considered the same. So you're talking about 1 in 14 people, 1 in 17 people will have an ulcer prevented if you give them this stuff. There was a great study that we did, looked at on ibuprofen. They gave people ibuprofen for a week, 4 times a day, for a week. These were volunteers. They had a stomach gastroscopy look at before the study, and at the end of 1 week, taking Motrin 4 times a day, virtually all of them had particular lesions, and none of them had, they said, well, are you having any stomach pain? The ones that were having stomach pain had the least lesions, and there was no relationship between their symptoms and what the stomach looked like. And you all seen people who have had NSAID bleeds. They come in, the first symptom of the NSAID bleed was vomiting blood. They weren't saying, well, my stomach's been killing me for about 4 days kind of thing. A lot of these patients have no pain prior to that, because NSAIDs are decent pain relievers. One thing to consider. What about this business about NSAIDs in heart attacks? The Vigor study was the one that basically said rifacoxib, Vioxx was associated with more cardiovascular events. This was a head-to-head with naproxen versus rifacoxib. So there were more heart attacks with rifacoxib. So the question was, is rifacoxib bad, or is naproxen protective? We got less heart attacks. No, and it turns out, no, that's not true. And it basically is concluded that Celebrex, ibuprofen, diclofenac all have similar issues regarding cardiovascular events when compared to patients not taking them. This is a class effect. It's across the board. It's not like, oh, this is the bad apple kind of thing. And like most things, they're not all the same. Some are worse than others, and it is dose dependent. But I think you have to be careful as an emergency physician giving out NSAID for some indicated. Well, you get a sprained ankle here. Take some of these NSAIDs for the next week, and a person who has coronary artery disease and is known to have it, when in fact NSAIDs and sprained ankles are no better than giving other low efficacy analgesics in those settings. So I think there is some issue here in those cases when you prescribe, even if you're going to prescribe for a relatively short period of time. 20 concluded that the increased cardiovascular risk of these ischemia events are about twofold for COX-2s and somewhat smaller for the standard NSAIDs. So the COX-2s are a little bit worse, ranging about twofold, increasing your risk. And there's a couple papers in here that said that's the ballpark, about twice as bad in terms of these problems. What about CHF? There is this relationship between CHF and NSAIDs, and it's an association. We don't have any good double-blind, randomized, controlled kind of things, but so we don't know about causality here. But where there's smoke, maybe there's fire. Like number 21 says, there's an association between the use of NSAIDs and in the week prior to admission for congestive heart failure. The odds ratio being you're twice as likely to have this be in the history than not. And particularly for first-time admissions, it's almost 3 times greater. So you start these people on NSAIDs for their arthritis, and they will go into the hospital. That appears to be a relationship, although we can't say that for sure. And then 22 is similar. They found an almost twofold increase in compared standard NSAIDs and COX-2s, and found both were associated with increased risk of congestive heart failure. So I think that, until proven otherwise, this does seem to be a real association. And congestive heart failure is, in the States, the most expensive diagnosis we have. Medicare pays more money for congestive heart failure than any other diagnosis. In terms of it's a fatal disease. If you were to pick between cancer and CHF, pick cancer. You'll live longer on average with cancer than you will once congestive heart failure is diagnosed in you. So this is an issue, and so the fact of the matter is if I think it would be reasonable for us to be aware that not only we're talking about ischemic heart disease, we're also talking about potentially congestive heart failure.
I mean, is there not possibly a relationship that older people have more degenerative arthritis, more likely to take an NSAID, and are also the same groups more likely to have congestive heart failure because they're elderly?
Well, a congestive heart failure generally is in the elderly, but in these two studies, they basically went ahead and said, what was the precedent? What happened in the week before? And they were twice as likely to be taking an NSAID than not. So they said maybe there's a causality here, but these studies don't prove that. It's just kind of like where there's smoke. What about this renal issues? Ketorolac is 23, a 17-year-old, got 60 milligrams IM of oral ketorolac for 10 milligrams for every 6 hours for 3 days, got a renal infarction. Some people think ketorolac's a good drug to use in sickle cell. This paper would, and this is a case study, so this may not mean that, a case study means it's so rare that we're going to make a case out of it. So it's not necessarily, it's either kind of like the canary in the mine. Here's the first thing to be aware of. Maybe there'll be others you should be aware of that we found one like that, like this, and maybe there's going to be a bunch more that, and now that we've identified this one case. So that's the rule of case studies generally is that talking about rare events. So this would have to be considered to be a rare event. But pathophysiologically, use of NSAIDs in sickle cell doesn't make a lot of sense because all of these folks are going through this process of killing their organs. Like, the kids, they don't have any spleen. They've auto-splenectomized themselves because during the sickling process, the pain of sickle cell is ischemic pain. So it's ischemic muscular pain, ischemic back pain, ischemic abdominal pain. It's like intestinal angina kind of thing. So the idea here is these cells are sickled, going into the organ, they cell sickle, the blood can't get into the organ becomes ischemic, and some organs are more sensitive to this than not, so that all of the kids, by the time they're 6, 7, 8, 9 years old, have no spleen because they have functionally had all of these ischemic episodes. Their spleen dies, so they're susceptible to these infections where the spleen was important, like the encapsulated organisms, the pneumococci, that kind of thing. So that was a risk. Well, anyway, the idea here is that ischemic blood flow to the kidneys may be an issue, and yet we're giving a blood flow inhibiting drug. So that is at least a theoretical reason why you could understand why this would happen. And then there's another renal failure case here, by a single dose. Talk about bad luck. Got a shot of ketorolac for incisional pain after a pacemaker was put in, went into renal failure. And then there's the ibuprofen and acute renal failure in kids. This is a case report. Number 25, an 18-month-old, got 1 week of a recommended dosing of ibuprofen. A lot of these kids are associated with decreased oral intake, so there's this issue of, well, where are they dehydrated? So you get a dehydrated kid, we're going to give them a renal blood flow inhibiting drug. And so, but I must tell you that we're talking, again, about case studies. There was a report of 5,000 kids on ibuprofen for fever, and basically concluded that in those 5,000 kids there was no problem. And then acute renal failure is 7 cases, is in paper number 26. This is 7 cases of NSAID-related acute renal failure in kids between 4 and 15. Only 2 are obviously clinically dehydrated, although 5 had weight loss, which means it's probably not in acute illness. It probably is water. 1 required brief hemodialysis. I personally, you see some of these hospitals where they have a firm belief that ibuprofen is the superior agent for fever treatment. Oh, geez, the kid's got 104, oh, you got to switch over to that ibuprofen. There have been so many head-to-head studies looking at this. The most charitable thing you can say is, most charitable by far is, it may be a little bit better in the kids who have the highest fever, and its duration of action may be a tad better in those kids. But it really doesn't matter. I mean, this isn't physiology laboratory, and kids got 104, just load them up. Here's the Tylenol, it's 15 per kilo. Give a splash dose so that you count for what they're going to wear. Take that out, so you be a little generous on that. Okay, we're going to give it 20 per kilo, considering the splash factor, and just give it. And sure enough, the temperatures come down. So and this idea of, well, let's give ibuprofen, and it's hard to defend that stuff. I mean, the literature's looked at it because it seems to make sense. but it doesn't really change much in the way of outcomes. So just give the right dose of a nice safe drug for the kiddies that doesn't inhibit their platelets, that doesn't screw up their renal blood flow and may not and cause issues with their stomach kind of thing.
And then they had this thing with over 102.5, you switch from 5 to 10 milligrams.
Yeah, this is such mumbo jumbo kind of thing. It's like, show me the papers. I mean, I pay attention to this stuff because I think this is in the realm of emergency medicine that we would get this down cold kind of thing. I've not seen any papers that say, you know, changing the doses. And the other thing is, why are we so aggressively trying to prove that we can get the temperature down? I mean, it's like, by the time they get 104, they're not going to seize. They already went through the stressful period kind of thing between going to 100, 104, so it's not really an issue. Some of these ERs won't let you out of the department unless you get the fever down. You ever see one of those emergency departments? You got a 104 fever, and you can't leave the nursing policy, you can't go out of there 101. Get that little bastard out of there, you know? Make the diagnosis of otitis media, give them the augmentin for 14 days, and get them out of there kind of thing, you know? It's ridiculous that you should have to, you could only send the kid out when the temperature's down. Like, what does that mean? Does it mean they don't have a serious disease? Not in any way. And then there's these papers in here about the progression of chronic kidney diseases. That's 28 and 29 and 30. 30 is important. It says a lot of the NSAID trials exclude high-risk and older patients because the NSAID trials are about proving how safe this stuff is. So if you want to take out of the people at risk, then you take out the old people and the people that have other diseases going on. And the last couple papers talk about fracture healing. Does inhibition of inflammation, see, inflammation is a part of the healing process, I guess, in fractures, and now you're going to inhibit that by giving this NSAID kind of thing. And so paper, according to 31, and 30, if you have a rat that comes in with a femur fracture, I would definitely not give a rat any NSAIDs in the first 2 weeks because it says it will. There's a long review paper that came out on this topic that we're going to be putting into the abstracts, which is looked at the entire literature. This is just a couple random papers. And it does conclude, you know, all things considered, it probably is a reasonable thing not to give NSAIDs in the first, 7 to 10 days after a fracture. All things considered. Why don't you just give them some Vicodin kind of thing, because fractures are usually not NSAID related kind of, they're not usually adequate for a broken bone kind of thing. And there is this kind of smoking gun kind of thing that suggests maybe you're not going to do the patient a real favor. And lastly, NSAIDs and asthma. 33, 34, and 35 say NSAIDs and asthma, that thing doesn't, you can give NSAIDs to asthma patients according to those 3 papers without any trouble.